Welcome back to the For Your Best Self podcast. It's Dr. Rebecca Novo. I am honored and privileged to be joined by Dr. Michael Murchland today in the studio. He's joining us, the Best Self team, as our Mohs surgeon with decades of experience in medicine. I think we counted 40 years in medicine, and that speaks to why he's part of our team of skillful, safe, and synergistic practitioners. So he's a perfect fit to our practice. So thank you for being here. Our goal today is to help you get to know Dr. Murchland and learn a little bit about Mohs surgery and how to really have the best experience and outcome. So a little bit of education and get to know Dr. Murchland. A little bit of background about Dr. Murchland. He's a triple board certified dermatologist, dermatopathologist, and Mohs surgeon with 25 years in the Air Force experience, graduating from the Air Force Academy. Happy recent Veterans Day, by the way.
Yeah, thanks.
In Bethesda, Maryland, and attended medical school, obtained his MD from the Uniformed Services University of Health Sciences, and from there did dermatology residency in San Antonio, Texas, and dermatopathology in Washington, D.C., with Mohs experience working alongside plastic surgeons for the past 3 years, so incredibly skilled at what he does. So we're very, very fortunate to have him as part of our team. And more recently in Ohio and Central Florida in private practice. So the best of both worlds. You've carried a lot of leadership positions too. I don't want to minimize that. He's been multiple chairs and chiefs and a lot of leadership. So he is such a great fit for our patients and for our practice. So thank you for being with us.
Thanks for having me.
Dr. Murchland recently recorded a little video for our staff to get to know him before his start here. And one thing that really resonated with me is he leads medicine with patience and kindness. And for some reason, that's a little bit lacking in medicine lately. And that's also another reason why he's a perfect fit for our practice. And I think that is a reason why he kind of culturally sought out to join our practice, kind of a mutual like-mindedness to put the patient first. So that really resonated with me to hear you say that you lead every day with patience and kindness for the patient experience. So in the most fundamental terms, I think it's helpful to teach patients, it's a scary thing to hear that you've had skin cancer diagnosis, and now we're kind of recommending Mohs surgery, and some patients think every skin cancer needs Mohs surgery, but if you could explain to our audience in the simplest terms, what makes Mohs surgery different from kind of your standard surgery where someone might have a skin cancer removed?
So the majority of skin cancers, if they occur in areas that we have the luxury to just take a little extra skin from the area, we get a good cure rate for those, probably approaching 95%. But it turns out to get that, you have to take about 4 millimeters all the way around the spot. And so if you add those together, that starts to be an extra piece.
Right.
That if it's on your nose or your lip or your ear or your eyelid or your genitals, you want to take out all the cancer, but you don't want to take out any good skin, right? And then it's routine for us, but it's a major undertaking for the patient to undergo one of these procedures and recover and return to their activities fully. And they want the best opportunity to get it done one time and have a good, functional, aesthetically satisfactory outcome. And so that's how the procedure came about, is to try and minimize the amount of harvesting of unnecessary tissue, right? And getting it done in one time.
Right. So kind of, if from a patient's perspective, what makes Mohs surgeons like you very special and unique is you are doing the procedure. So in your mind's eye, you know the kind of the target, the cancer. You're prepping the patient and you're excising the target, and then you personally are then looking under a microscope and making that call. You know, we kind of tell patients we're going to look at all the edges and then just make sure that that whole perimeter's clear. Is that kind of how you would describe what you do from the procedure through that process of getting a cure or getting a clearance?
Yeah, absolutely. So the unique thing about Mohs surgery is the surgeon and the pathologist are the same person.
Right.
There's a continuous chain of custody, if you will, from when the patient walks in the door until the patient walks out. And when we take the specimen, the first layer that we harvest, we orient it. We put special tiny little marks on the patient, and when we orient that on the specimen, we take it to the laboratory and we put different colored inks, and then we make a map, and so that we know kind of the orientation of the specimen when it came off the patient. If we look at it the first time that the technician makes the slides and there's no cancer on any of that, then we're done. We repair. Sometimes we look and there is a little bit of cancer, but you don't want to take another whole piece the size of the first one. And so when we look at those slides, I can look at where it's at and determine, okay, it's at 6 o'clock on the disc and next to the black notch with the black ink. And so then we look at our map and we say, okay, that little area is at the bottom of the chin or the tip of the nose. And so we go back to only the area where there's cancer and take a little more so that we don't take it from the other areas. And by doing that, we get the cancer all out and then get the highest cure rate.
Right. So it's the highest cure rate with the most kind of precise tissue preservation. And that is really important when you're talking about areas that, you know, you can't just loose skin pinch together, be generous. Nose, lips, ear, eyelid. And there are some indications for body as well.
Yeah, the size of the tumor and the characteristics of the tumor under the microscope. So if the pathologist writes back and tell us that this is a particularly aggressive or invasive variety of your skin cancer that tends to grow in little roots or little tiny collections, then that will change the indications where we can do it in those places. So, and I should add that it's difficult to describe, but this traditional method for processing a skin cancer specimen in an area for just ordinary excisional dermatologic surgery.
Right, like formalin.
Yeah, they put it, it's called bread loafing. And so it's prepared in a way that gives them reasonable examination of the margins, but technically speaking, that procedure only examines about 1% of the surgical margin. And so for the majority of tumors, like basal cell carcinoma, it tends in its most common form to stay cohesive just all together. That works really well. Right. But for the varieties that grow as little roots and kind of dissect between,
infiltrative,
we actually turn them the other way, and so we process it as a disc or a saucer, and in that way, and then we cut the edges at a special angle. I won't get into the technical parts, but it allows me to see 100% of the true en face surgical margin, and that was really the reason we call it Mohs surgery. Is Dr. Frederick Mohs brilliantly came up with that idea back like in 1933 while he was a medical student, while he was a research assistant. Yeah. And
it's incredible.
Yeah. And ironically enough, he was up in Wisconsin, where we're headquartered. Yeah. In Madison, though, not Manitowoc. But at any rate, and so that's why we call it Mohs surgery, is Dr. Frederick Mohs pioneered the technique back in the early 30s and then did a lot of surgery with it, improved it, got very high cure rates. But then it's evolved. And so later, probably if that was in the mid to late 30s. It was done that way until about the mid 70s. And what they did back in the day is they put a chemical on the patient and allowed it to process the tissue. It would render it so that it could be then removed and processed in the laboratory. It worked very well, but it was laborious. It was slow. So they put it on, and it would have to incubate overnight.
Oh, wow.
Then you come back, and they take one layer. And then they process it and look at it. And then if you needed another layer, they do it all over again. And so, and then it was brilliant the way he came up with doing that. But it caused a lot of irritation and inflammation. So then you had to leave it alone for about 6 weeks till that chemical kind of peeled off on a big scab, and then they could start putting you back together.
Wow.
And so I wondered, why did it take 40 years for them to come up with the way that we do it now? And so then I finally looked it up and realized that they didn't have adequate refrigeration until the late 50s, early 60s to make a cryostat. So we use a machine that's basically a miniature deli salami slicer in a very cold refrigerated box, right, called a cryostat. But the first one of those really wasn't available until 1958, and they didn't really get into hospitals and clinics and places for another decade. And so at any rate, but in the mid-70s, some other doctors, Dr. Stegman and Traumovich, and then Perry Robbins kind of put the articles out there and showed. And that's the way we do it now. So it's been a technique that's been around for 90 years. But it keeps getting refined.
So very special equipment, very precise special procedures to get really the best cure possible for skin cancer. And I think some patients will say, oh, my friend had Mohs, or they kind of generalize skin cancer needing Mohs, but we review every pathology and just make sure that it is a real clear indication or that there's a strong why to have Mohs.
Right. Well, I think we have to be careful. It's there's an old saying: when you have a new hammer, everything looks like a nail. Right. It takes a lot of resources to do Mohs, and it's expensive for the insurance company to reimburse for all that stuff that we do.
Right.
But we're careful to only apply that technique when it's necessary.
Right.
And so every case that I do, I apply, there's a set of appropriate use criteria, the AUC. I have a little app on my phone, which makes it easier. And we run it through there to make sure that it's appropriate.
Right.
And we just feel that it helps address a potential conflict of interest that doesn't need to be.
And that's part of our job, to kind of guide the patient into the best treatment, best cure. We work together with our dermatology colleagues, our PAs and nurse practitioners and dermatologists, and based on the diagnosis, we work together to, recommend Dr. Murchland, who would review and confirm the plan for any given patient. So if I was coming in to see you for Mohs, in best case scenario, I might be there for an hour, or kind of what's the fastest to longest potential, just so I can mentally prepare myself.
It's always better to over deliver and under promise than the other way around, right? And so on occasion a patient is in and out in an hour or two, but depending, there are cases that take the whole day. Right. Once in a while, a patient goes home and sleeps and has dinner and comes back. Right. Right. So that can happen, but those are the exception rather than the rule. Yeah. And so, but it is incumbent upon us to try and help tell the patient what to expect. So I tell them, most of the time we break it into a morning and an afternoon set of procedures, and so I tell them, plan on spending about a half a day with me. Yeah. If I get you out sooner, hooray. If we run a little late, we have snacks. Right. So we get you through it. But it's not entirely predictable on what we're going to find. Right. Sometimes a big tumor comes out in one stage, and so and you're out the door. And sometimes a little tiny dot surprises us.
Absolutely. I've I've participated in some of those surprises.
Yeah. Hello.
I was not expecting this.
Can you help me?
Yeah. Yeah.
Yeah.
Yeah. One of my favorite sayings is hope for the best, prepare for the worst, because that's the only way to kind of set that expectation of we want you to leave with a cancer cure is the goal.
Mm-hmm.
And we'll see to it. In your best advice, what are a few top, like 2 to 3 things to avoid before I come in for my Mohs procedure?
Yeah, good question. So, given my longevity in the field, the guidelines of some of this has changed,
Mm-hmm.
right? So, there was a time, and you may not have been practicing yet by then, where we would actually attempt to have the patient stop prescription blood thinners to do the surgery.
Mm-hmm.
And for good reason. I mean, you can have
Mm-hmm.
bleeding, you
Mm-hmm.
can have, especially if you do a big repair, that can cause some issues. Fortunately now, though, with evidence-based medicine, they've studied it and figured out that it's safer for the patient not to stop their prescription blood thinners because, they may get a bruise. They may have to come see me in my PJs in the middle of the night if something starts bleeding. But that's much better than a heart attack or a stroke, right? So I guess the first thing I tell them is if you're on a prescription blood thinner, just keep taking it.
Right.
Now, there are circumstances where they may want to call their cardiologist, or their...
Right. I've held it before.
Yeah, I've stopped it before, But in general, I tell them keep taking it. Number 2, if it's not a prescription blood thinner, there's this whole cohort of patients that just take an aspirin because I did for a while because it may prevent some problems unless you fall and hit your head then you have other problems. So, but if you're just taking it for prevention or you have a few squeaks in your joints, then probably best if you can stop it to do that.
You say about a week?
10 days for aspirin, actually. Yeah, it's only about 3 days for Motrin or the other, non-steroidal things like naproxen and whatnot. Aspirin is the big one. It's surprising. It's like 11 days. If you forget and take it, I'm going to do your operation anyway. And so it's okay, but it's just less likely to have problems. The other thing we encounter is patients are very accustomed to having no food by mouth after bed, from many medical procedures. And so we try to let them know, you're going to be awake, and go ahead and eat. If it's your custom to eat breakfast, go ahead and eat breakfast.
Right. Encourage.
Because if they don't, then they start to wilt part through. And so we keep a close eye, and we give them snacks, but particularly varying degrees of diabetes is not uncommon, and so we don't want that to be an issue. Eat breakfast. And then some patients, I've had this so many times, they're completely relaxed. Some patients are absolutely terrified and they don't sleep the whole night before or the whole week that they know they're coming to see me. And so if you know ahead of time that you're just quite nervous or that you just are not going to sleep the night before the procedure, just leave a message for me. I'll call you back. We'll discuss it. And some patients, now I don't want you driving to the clinic after you've taken, some Valium, but we give you something to tamp that down just enough to get through it. You don't need to be miserable.
Right. Strongly agree. And I think another pearl for planning your procedure is make sure your schedule allows healing. We expect to see you for a follow-up, between a week or two, and in a perfect world, you don't have any really major trips or events or things, even physical activity planned in that next week. It might sound like common sense or no-brainer, but when you're kind of put on the spot to schedule, we really want to balance that with making sure that timing makes sense for your procedures to avoid complications.
Absolutely. I tell them check your calendar because I've had circumstances where we take one stage and then we tell them we need to take a second stage, and they go, no, I got to go close on my house. I'm like, what? And so we bandage them up and they go and they come back. And so, I've had ones where we do a big repair and they say, okay, now I'm going to get on the cruise ship in the morning. And you're like, did you book the room next to it for me and my technician? Because what are we going to do? So you have to think about that. The patient stays awake, but they should plan a ride, probably, right? Yeah, sometimes they'll come and they go, it's on my hand, it's okay, I've had a dozen of these. But certainly, head and neck, around the face, if I put a big eye patch on you like a pirate, I don't want you
visibility,
driving.
yeah, and comfort.
Right.
I agree.
And the other thing is just many patients are caregivers to grandchildren, a spouse, another family member, or a pet. And so sometimes if we have to have a contingency plan, you know, Sparky, my faithful dog, is fine if I get home by 4, but if I don't get home till 7, there's a problem. So I have to have the neighbor come and help with that. So those are some of the things we think about.
And then is there any time that you're recommending, we talk about radiation therapy, but in dermatology, it's really kind of superficial radiation therapy as a potential treatment option. When do you recommend that to patients as a consideration over surgery?
There are naysayers, but I think the technology has come a long way, and I've had a lot of experience with it. And so, we, like you alluded to, we had to be careful that this is superficial radiation for the first time a tumor has been treated, and a tumor that's not a very large, very deep, very high-risk tumor, right? So there's a whole other discussion about patients that have it as part of their treatment after their surgery and all that. And for those patients, we consult radiation oncology. But we do have a very useful tool now, SRT-100. And SRT-100 is that particular machine is made by the Census Healthcare. And it's been around for more than a decade now. But it allows us to do radiation treatments in the clinic. And they are short, they're painless, they don't put any mark on the patient, very few side effects, maybe a little bit like a sunburn reaction, and they have high cure rates. You know, local control is called LC, and the local control for those carefully chosen tumors in the right patients is 78 to 98%, which is very good. And so we have patients sometimes who've had many operations, and at some point they get tired of having more operations, and so they elect to have the radiation. We have patients that have other medical issues going on, and they're not the best candidate for surgery, and so we'll do the radiation for them. We have patients who are just very concerned, rightfully so, about an operation on the tip of their nose or their lip or their ear, and the short-term cosmetic outcome is superior to surgery. Now, we don't do radiation on 30-year-olds because many years down the road, decades later, you can get some discoloration, a few spider veins, things like that. But if you're, 50 or older, you're probably a good candidate for it. So it's not magic. It's not going to put the surgeons out of business, but it's a welcome tool to have in our toolkit because if you're the patient that matches for and that's what you elect to do, we can give you a good assurance of clearance of your tumor with good long-term results and no stitches, no bleeding, no bruising, none of that stuff.
The key in that treatment particulars you had mentioned is frequency. Like it's a commitment as far as a number of treatments. Yeah,
it is. It varies a little bit, but we're talking on average 13 treatments. And so, if you can get done, if you come Monday, Wednesday, and Friday, then you're done in 4 weeks. And so there are certain rate limiting things. If you live nearby, it's easy. If you're coming from out of town, it's not as feasible.
Right.
And so, but I'm happy when it's there because it's just occasionally, a patient that might elect not to have anything done.
Right.
And they'll do that and they do great.
Yeah. I know we touched on comfort a little bit, but I think that is one of the biggest fears of anyone having a procedure. I appreciate that you'll offer something for anxiety if that is important to get that patient there. I kind of tell the patient half the battle's showing up, right?
Absolutely.
So getting there, a little bit of pre-procedural anxiety, there's tools for that. And then otherwise, we are injecting a numbing anesthesia. And then beyond that, it's, I think, reassurance. I think it's bedside manner and just making sure that patient feels safe and comfortable. Is there anything else you want to cover as far as comfort for the patient?
Yeah, absolutely. Sometimes it's the little things, right? Fortunately, I don't know if they can do this anymore, or we certainly did in the military, but when I showed up, many of us were already physicians of other, my classmates were the head of pediatrics, a boarded internist, and I had been a flight surgeon for 3 years. So we were somewhat experienced physicians. But when we showed up to our dermatology residency, the first week they didn't let us touch actual patients. We're like, but we're real doctors, and they said, oh, no, you're going to do some of this stuff on one another. And so we injected each other with the local anesthetic, with it cold out of the refrigerator versus letting it warm up to room temperature. Oh, wow. Huge difference. You got to let it warm up.
Okay,
right?
Cold is not good.
Cold is not good. Same goes with some of the dermatologic drugs, right?
Yeah.
The other thing is we use the anesthetic has some epinephrine in it, and we're really happy it's there because it really helps control bleeding, and it's great.
It's my friend.
It's your friend, but it's sometimes not the patient's friend because it stings like crazy, and if you don't believe it, you can give yourself a shot with it. I don't recommend it. Especially you can imagine your nose or your lip or something. Right. Well, it turns out some smarty pants pharmacologists taught us that if you can change the pH, the reason it hurts so bad is they have to make it acidic.
Yes.
Yeah, and so at least it takes a little bit longer, slightly bit more effort. But if you just put a little bit of sodium bicarbonate in there.
Yes.
And when you do it, I get a tear or a lump in my throat. Sometimes you put that in there, and it's a patient who's had injections, and sometimes there's a dozen injections in your nose. And the patient is like, I don't know if I can do this. I don't want those shots in my nose. And I go, trust me, let's try it this way. And we put that in there, and we do it, and they go, it didn't hurt. And they go, what did you do?
You're good.
Yeah, and you go, I'm not Marcus Welby. I go, well, why? And I tell them what I did, and then they get kind of mad. They're like, how come my other doctor didn't do that? I'm like, I don't know. But,
we do buffer all our local.
Yeah, you got to buffer it because, wow. And that's such a little thing.
Meaningful.
Yeah, and especially if you have multiple stages with me all day long, we keep injecting the same spot. You just get worn out from that. So you will feel the needle, but I take pains, pun intended, to try.
Great pains.
Yeah, we take pains to avoid that, right? And then it depends, it's part of, I tell the patient to feel comfortable advocating for themselves, right? They have agency, they can speak. And so everybody's a little different.
Absolutely.
So some patients, and I ask them, what do you want to do? So some patients, they want me to talk to them the whole time. And if I get them talking about their pets or their family or their grandkids or their hobbies, the time goes by. One fellow was a race car enthusiast, and so I found something I saw on YouTube, and I let him watch my cell phone watching this thing about this car going through this, he would watch it, and then he goes, well, what are we going to do about my nose? I go, oh, you're done. And he goes, what? We do that.
That's awesome.
On the other hand, some patients, they don't want all that chatter. It makes them crazy, or they think if you have time to talk, you can't be focused. Concentrated on my face, right?
Right.
Some like music. We let them pick
37 years of
we let them pick the music.
Yeah.
We listen to the music they like, not the music we like. Right. Some of them want the nurse to hold their hand. We even had one that was so nervous I didn't think we were going to get through the procedure, and so we did everything. We dimmed the lights. We had the nurses hold her hands. We turned on some music, and we said, and she's still, I don't know, we're going to make it. And I'm like, I said, I don't know what can I do to help you? What's going to get us through? She goes, you're not going to want to do it. I go, well, give me a try. She says, you're going to have to sing to me. And I go, and my assistant was this huge guy who played football in college. And so he looks at the patients and he says, okay, what do you want? You want Hootie and the Blowfish? And he was going to sing her some songs. She goes, oh, no, none of those. And she goes, I want Sinatra.
Oh.
And my technician was much younger than me, and he goes, "Doc, you got to help me here. I don't know any Sinatra tunes." And so I said, "Okay, what do you want to do?" I only knew a few, and so I said, "Let's do Fly Me to the Moon." Sang Fly Me to the Moon. Next thing you know, she's completely distracted. We're operating along, and then she stops us, though, because there's this part where Sinatra goes, "Darling, kiss me." She goes, No. I used to rehearse this in front of the mirror at home when I was 5 years old. It's "Darling, kiss me."
Oh.
I'm like, okay, so whatever it takes.
It's a very personalized experience. That's incredible. That I think it's such a human experience, and I would agree with you when you said we might have done this 10, 20, 30, how many thousands of times, but most often it's that that patient in front of us first experience. And I give the same analogy, and it was incredible to hear you say the same thing, that it's just a humble reminder. It's such a human experience every time. We don't take that for granted.
Mm-hmm.
Just reassuring that patient that that's not lost on us, I think, goes a long way.
Yeah, well, we forget is it work? Yeah, it's work. At the end of the day, is my neck stiff? It sure is. But it is an extraordinary privilege that we have, and you know this. The way the patients trust you, the intimacy that they afford about their fears and their hopes and what's going to make them feel whole. That's a tremendous trust, and so we have to care for that and take care of it.
I don't know if I can say anything more. Is there anything else you want our audience, our patients, to know about Mohs? I think comfort is key. I think we covered that very completely. I think skill is there, experience is there.
We'll refine our handouts, and I know they get telephone calls, but sometimes the information is going by pretty quick. So I tell them a couple things. I said, bring a book or an iPad, crossword puzzle, Sudoku, your reading glasses, a snack, especially if you're diabetic. I promise I won't steal your snacks. A sweater. I'm always kind of hot and sweaty, but some patients, we keep it pretty cold in there. Even if you don't need a ride, if you bring a friend or a family member, it's just good to have a companion, because there'll be times when you're sitting waiting to hear the results, and those go by quicker. Those are the main things for that. I do tell them to, it's okay if you remind me, each time I see you, remind me that you have an implanted defibrillator. It's okay. I want to know that. It's okay to tell me for the 20th time you're allergic to penicillin. I'd rather you tell me 20 times than right at the end I write a prescription for penicillin because I'm busy. It's okay if I'm busy and you didn't see me wash my hands or put hand sanitizer on before we start. They're not going to hurt my feelings, right? And then just a couple things. In fact, some people, your colleagues, have taught me, the facial plastic surgeons. I wouldn't have believed it till I saw it up close and personal, but ice in the post-op period. So we talked about before, during, and what do you do after? Never underestimate the power of ice. And so we just have them. Sounds silly. You have to tell people how to, they have fancy ice packs and stuff. You can get these gel ones and everything, but I say, you don't need a fancy one. Get a Ziploc bag and throw some ice cubes in there and seal it up and have a couple of them rotating. On for 20 minutes, off for 20 minutes, on for 20 minutes. And they go, do I have to wake up in the middle of the night and do this? I go, on 20, off 20 till you fall asleep. And you're going to wake up in the morning with a Ziploc bag of melted water and toss it. But if you do that for the first, depends on how big of a procedure, first 12 hours to the first 72 hours, depending, remarkable difference. Remarkable difference.
I say the same thing. And then otherwise it's kind of Tylenol, extra strength Tylenol level comfort. There are occasions when we need to prescribe an opiate, but I think the pendulum has swung one way and then too far the other way maybe. Will I prescribe it if it's necessary? Yes. But I also try to go by evidence-based medicine. And there are studies now that show that alternating
extra strength Tylenol and Motrin, which
Right.
sounds too simple, too easy, but it's as good as a narcotic, and you don't get the other side effect
Right.
like constipation and nightmares and
Migraines.
and falling and hitting your head and breaking your
Right.
hip and all the other
Right.
stuff, right? So, but I'm not going to ignore you and leave you in pain,
Right.
right?
It's such a personal experience. I typically say it's available, but usually the side effects are worse than the discomfort that we can manage with Tylenol.
Right.
Yep.
And then I am amazed and humbled. I have patients that they want to know how soon can they go be in the pickleball tournament
right.
this weekend,
Yeah.
right? And I'm like,
Golf, tennis.
You're 82 years old. Yeah, so what? I'm like, yeah. And so you really do need not to have a lot of strenuous activity because I don't want you bleeding. I don't want you to pop your stitches loose.
Right.
We used to say no swimming. I still kind of hold. I don't want them to swim in the Halifax River, although there are studies now that show that it actually seals up pretty well. You can take a shower like within
3 days.
Sooner,
Yeah.
like 12 hours. It's sealed for a shower. But don't tell the patients I said that because they want to go barefoot water skiing in the river, and I'm like, no. I don't want some aquatic bug in there.
Yeah.
But then I think patients use good judgment. But I make myself available, and I tell them, if you're bleeding more than just a little bit on the thing, if there's a lot of blood, and I don't try to scare them, but if that happens, call me.
Right.
I do warranty work.
Right.
Only once about every 5 years do I have to come in my PJs.
Right.
But we're here for you. And if you need that, we're here. And then I think that's, we give them wound care instructions, and I can tell the difference between the ones who actually do the wound care and the ones who don't. And sometimes men don't pay close attention. Maybe they're not as accustomed to putting things on their face. I don't know what the reason is, but the wound will heal quicker and it'll look better if you actually do the stuff we say. And just a little soap and water, a little bit of Vaseline. There are all sorts of fancier silicone gel sheeting and all sorts of other things that can be made available to them. And then when it's all said and done, once we're past the initial healing phase, they happen to have access to the full spectrum of other things. You can do some lasers, you can do some other things to help with that. Now, hopefully they won't need it.
Right.
But if they do,
we're there.
It's here.
Yeah. Yeah. I couldn't agree more. I've personally learned a lot, and I think our patients are so fortunate to have you as part of our practice. So I'm super grateful. Anything on a personal note that you want patients to know about you?
Let's see. So although my extended family is from around the western Pennsylvania, Pittsburgh area, I'm a South Floridian. I grew up down Miami, Hollywood, Fort Lauderdale. Yeah. And so I love the water and boats and fishing and all that kind of fun stuff. And campers. Usually you'll find me twisting wrenches on an old car.
Love it.
Or fixing a camper or an old boat. And my wife's always looking at my hands going, remember, should you be working with that saw? And I'm like, well, I still have 9 left. It's okay, right? So that. And I do have 2 daughters, 2 adult daughters, and they are doing great, 35 and 32 years old, which surprises me. Enjoy yours.
Yeah.
They are there
Every
so quick.
second.
Yeah. And then our first grandchild is here and is a year old.
Wow.
And that is just spectacular.
Yeah.
So
look forward to it.
Look forward to it.
Well, thank you for your time. This was incredible, and I look forward to taking care of patients with you. If you want to learn more about Dr. Murchland, his bio is on our website, www.foryourbestself.com. His schedule is live. He's got a full schedule this week in our Vieira location, Vidina Drive. And if you need a consultation, you can call our office at 321-241-1160 or reach out with any questions. Thanks for tuning in. Share this with someone you love.